draft of visit agenda for your October visit at the moment. We will plan to send you for comment by the late next week, roughly end of the month.
Say that again. For when the
Yeah,
visit.
yes. So we target to send you the late next week for your comments and input for anything that you feel it should have been in but not in. So you can suggest us to add it.
Well, I think what we have to do is we just said is we're going to be looking, I was waiting to hear from you folks primarily, what your thought that's what the benefit would be on this trip. That would be the first.
Yes. We are polishing more and then we send you.
Okay. Email. So that hides here. This goes here. View.
ไก่อาจารย์สุรพลเข้าไหมเอ่ย
อาจารย์ไก่ส่งไลน์ลิงก์ให้อาจารย์ไปตั้งแต่เมื่อวานแล้วอาจารย์กดอ่านแล้วนะคะเดี๋ยวไก่ตามให้นะคะอาจารย์
Please wait for Dr. Surapon a little bit.
Say that again. Shoot.
Please wait for Dr. Surapon a little bit.
Okay, great. I'm trying to find out how to eliminate something. No, that's not it. I'm trying to do slideshow, but this time it's making me just fill up both screens so I can't see anything. So I'm going to try and just do it the way with a little bit of side margin.
No worry.
Just make sure it shares.
We have not yet seen it. Oh, yes, we see it.
Okay. I don't know how to make it so this goes away because when I do it, it fills both of my screens and I can't see anything. So, Custom slideshow. Okay, I'll just do it this way. So we're waiting for Dr. Sirpol or
Yes,
others?
Yes, Dr. Surapon is the main one, but apparently is contacting him now. Please.
All right. Well, it's a this is more of a first introductory talk. He said CME sort of training. And it just gets it's one of the things he likes is a lot of times to see the history of how we got to where we are. So I'm covering the this is like part one of multiple myeloma. You can't do all of myeloma in one session.
Dr. Richard.
Yes.
Just sad news coming in. Sorry, Dr. Surapon have some sad news of his
family member.
Yes. So yeah, the go to joy God in heaven.
So is he even going to be on today then, or?
Oh no, because of the death in the family member.
Yeah.
So we will go ahead without him.
Okay.
Yes.
Well, again, I know that you sometimes store some of these, so this will be like a review. And I know I see our two pediatrician people on there, so I know the pediatric transplanters are going to be really interested in myeloma transplant today, because myeloma is a pediatric health menace. That's a joke.
You're joking, Richard.
All right. Anyways, then I will start because, and I'll just tell you, share some thoughts along the way, and we'll see how far we get. I'll go back to
I
sharing.
think the process, like a car in any disease, any kind of disease, I think it will have some benefits for us.
Yeah.
Thank you so much.
Yeah, I was going to make it two parts. This part was going to be like how we got the last 30 years of transplant, and then next session will be on a lot of what we're doing with CARs versus bispecific antibodies and other alternative therapy. So it won't just be CARs today. I mean, it won't be CARs today, but that's okay. So this is going to be a myeloma. I said it's how we improve patient outcomes. How do we advance therapeutic interventions? Which is always the goal of therapy. And basically, where have we gone and where have we been? What's the history? So, first of all, for the myeloma in general, this is your general presentation also. It is a clonal neoplasm. It's a terminally differentiated B cell. In the United States, in 2022, there were 34,000 new cases, of which basically a third of the patients, well, you also have the equivalent of a third of the patients dying annually. So it's currently considered incurable with the typical therapeutic modalities we offer. There is potentially you can cure with the donor transplant, but that's very infrequently used. And it's got specific staging details, which I'll show. What does it look like? The characteristics from a bone marrow aspirate, the characteristic definition of a plasma cell is where you have a heavily blue, quite bright blue because it's making a ton of RNA because the Giemsa stain will stain for RNA, which turns on, and all that RNA is turning out the protein that these cells are making. The nucleus is always eccentric, it's always deviated, and there tends to be next to the nucleus, a clearing, what appears to be a clearing, and that's thought to be the Golgi apparatus that's just secreting and stimulating and translating tons of protein. It's when you do it, we often make the diagnosis from a biopsy. You can get, like I said, that was an aspirate. That happened to be a very sparse to show the detail. You could sometimes, sometimes myeloma is so packed that you can't get a really good aspirate, but you can see when you can get an aspirate the blood clot, and you can see here in this bone marrow clot, although, like right here, I don't know if my arrow shows up, but here you have a eccentric nucleus, and it's got that oval, so you can say, oh, that's a plasma cell, that's a plasma cell, and you realize this is all plasma cells. There's another one, they all have it, and then you can get a biopsy, and again, it takes a long time to really understand, be able to translate looking from a bone marrow smear where you can actually get individual cells to looking at biopsies, but you can tell these are all have this. It's very homogeneous population of cells with a dark nucleus and a little bit of eccentric, and it seems to be always displaced to the side. Myeloma has a multiple other abnormalities. Sometimes you see, like in this case, it's a dual nucleated, a binucleated cell. But we use stains these days. Hematopathologists don't ever trust what they look at. They have to stain. And so here's where you look, and with a kappa stain, which is a light chain, usually we have two light chains, which is kappa and lambda. It's usually 55% population in a healthy population is kappa, 45% lambda. So you could see this is almost 100% kappa positive. And now we also look at CD138 as a clear-cut myeloma marker, and you can see this is all positive. It's just sheets in sheets of myeloma. What happens is it replaces the healthy hematopoiesis, and people will present with one of those presentations is anemia. The monoclonal gammopathies basically has been defined in, it has to be monoclonal proliferation. You usually can identify a immunologically characteristic protein, and there's basically a five characters, five categories of disease. One called monoclonal gammopathy. That's our benign monoclonal gammopathy. And you could see that you could, over 30 years, you could follow that and see evolution to actual myeloma. But many patients have a very low level, and don't ever progress to myeloma. We now have symptomatic myeloma, which is our classic CRAB criteria: hypercalcemia, kidney involvement, anemia and bone disease. And in between is asymptomatic myeloma, smoldering. So again, this is an accumulation of the clonal plasma cells. This may be very low level, under 10%. This may be 20, 30% cells. And this is when you get symptomatic, where it's now causing impact. We can also sometimes see where it erodes the bone in the solitary plasmacytoma, and that has a different treatment. You can just treat it with radiation, single site radiation if you have a solitary. But then, of course, you have this very aggressive, on the other hand, a very aggressive presentation with plasma cell leukemia that has a high mortality rate. Clinically, it presents with failure to thrive, malaise, weight loss, fever, anemia, 20% of patients, elevated calcium, 20% of patients, bone pain and lytic, with compression fractures are one of the most common presentations. Light chains can actually can filter through the glomerulus and poison the renal tubule. And when that happens, you can actually have kidney presentations. Myeloma characteristically has hypogammaglobulinemia and the other groups with recurrent infections. You can also have other more advanced disease where the myeloma of cord compression could either, the myeloma could either have a vertebral collapse and cause cord compression, or it can grow out of a vertebral body into the paraspinal space and actually lead to neurologic presentations. Hyperviscosity and defects in bleeding are rare. We have characteristic staging. Dury Stammen, this is Brian Dury, Sid Salmon. They were together at one time, University of Arizona in the United States, and they built this criteria of staging. And stage 1 is stage 2 and stage 3. Stage 3 is very advanced. Stage 1 is very low. A or B is in the setting of kidney disease, and it does seem to link with disease burden. Now, this isn't really important that much anymore because it's not as prognostic as what is the international staging system, which is very simple, as opposed to Dury Salmon, which is complex with multiple things have to be tested. However, in the United States, we still have to use in stage patients by Dury Salmon because stage 1 myeloma historically had a good long-term prognosis, and our current Medicare, our governmental support, will not cover a Dury Salmon stage 1. It would, so even though the international staging system is better for predictive survival, the ISS stage does not impact insurance coverage at the governmental level. And so, but we increasingly, though, you'll see publications focused on the international stage. You can see the difference in median survival. Again, this is 20 years ago, so survivals have all improved, but it was used to be 5 years for stage 1, 3.5 years stage 2, and about 2 years, 2.5 years for stage 3. We know that that's a staging system. The prognostic factors, though, often linked to disease burden, which means the higher disease burden, you're going to have more likely lower anemia, lower hemoglobin, and you'll be, which is stage 3, elevated calcium, could be stage 3, more bone lesions. Increasingly, we're recognizing, though, we don't pay it as much attention as we pay to cytogenetics. The 414 translocation, 1416, 1620, chromosome 1 abnormalities. IgA was always thought to be a little worse than IgG. My bone marrow microvessel density was popular for a while. People don't pay attention to that anymore. It's mostly just based on the state, the beta-2 microglobulin, the albumin, the LDH, cytogenetic abnormalities, as well as these clinical characteristics. We do have chromosomal alterations that are easy to track. Many of them involve the immune globulin locus. This is a cyclin D1 to the immune globulin locus, the 1114 translocation. It's a good prognosis, and it also is the only myeloma subset that can respond to venetoclax. The others do not. These are other sites where we see translocations, and you have other translocations involving genes that are more, potentially higher risk to the individual. The 13 deletion is important. Chromosome 13 deletion is where, your retinoblastoma protein is. It only really matters if you have it in cytogenetics. So if you see a cytogenetic profile which measures metaphases, if you see chromosome 13 deletion, that is a negative prognostic factor. It seems to correlate with a translocation 414. If you see it on FISH analysis, that's looking at, cells that are quiescent. It's interface studies. A 13 deletion there is not clinically significant. Some of the new diagnosis myeloma studies, there was one study from France when 30% of all new diagnostic patients, new diagnosed patients had a chromosome 13 deletion, all in the absence of that was on FISH, but not on cytogenetics. They were all normal. Things that are being developed, of course, are genetic profiling. People are looking at gene expression profiles. John Shaughnessy from University of Arkansas, he's in industry now, studied 532 patients, looking at control healthy patients versus myeloma patients. And what he was able to show is that you can actually show a signature that was, red is often hot. This is a high-grade myeloid. This is human myeloma lines. By definition, they're transformed, and but red tends to be a more aggressive phenotype, blue not. These are normal plasma cells. This is MGUS. But if you take this myeloma, you can actually start to see a stratification, and that stratification, that transition to what would be like plasma cell leukemia, was also associated with worse myeloma. And what they did is they came up with a signature of 70 genes. They ultimately were able to bring it down to 17 genes. And there was a commercially available study looking at those 17 genes. If you choose to want to do that on your new diagnosis patients, currently most people still do not use next-gen sequencing or mutation analysis. They still stick with FISH only. If I look at treatment, where have we been with myeloma? Well, it actually goes back to 1962. It was the first time melphalan was an alkylating agent. Remember, the history of melphalan is it was after World War I. It was noted that patients exposed to mustard gas in the trenches, if they didn't die of pulmonary toxicity, because that's the mustard gas would burn on contact. They could get they could also get, skin burns, but they noticed a number of those patients that their blood counts fell after 2 weeks, and some of the survival, their white counts came back. And they realized that the mustard gas had a toxin on the bone marrow, which ultimately was mustargin or nitrogen mustard, which was part of the first MOP, but of treatment of Hodgkin's. But nitrogen mustard is ultimately the source of all alkylating agents. And melphalan became a stable alkylating agent that could be taken orally. It was first used in myeloma, now 60 years ago. We then, about half a decade later, we saw the first big innovation, melphalan and prednisone combination, 2-drug therapy, median survival less than 3 years for most people. Very low CR, but the combination therapy was superior to individual, and we're starting to now see a new, basically a new approach. Then we got to VAD, which is vincristine, adrian, dexamethasone. That was shown, that was launched because those were individual drugs that myeloma was sensitive to. There would turn out to be higher rates of complete remission, no increase in overall survival. That was shown in a randomized trial in the United States of VAD versus melphalan and prednisone. But sort of then, now we get into the 80s, and what they realize is that you could take this is low dose oral melphalan taken monthly. But if we took it in a high concentration all at once, that there's a steep dose response curve, and that was capitalized on attempts to use. This is Ray Poles from Wales in England. They were the first to demonstrate that dose escalated melphalan could lead to marrow toxicity that also could be exploited with marrow rescue. And Bart Barloghi, was the first to took that first observations from Ray Poles and ran a clinical trial for autologous bone marrow support. We then get into the transplant trials, that the seminal trials that changed practice. Was the first one was that Tall et al., which I'll show you, is the first randomized trial of autologous transplant. We then go the evolution continues of multiple variations on a theme of transplant. And then, but this was all chemotherapy based till around to the year 2000. I think it was 1998 was thalidomide appeared. Around 1999, 2000, 2001 was bortezomib, and right after that was Revlimid or lenalidomide. So the biologics changed everything, but throughout this whole thing, we have very few cures. So where are we now in transplant? The biggest question, one of the big questions is, should patients still go to transplant or not? That is a current question. And I would say the answer as of today, based on what we have now, is yes, transplant remains a standard of care. Will it stay that way? That's to be determined. As far as in the United States, transplants, this is the data from the Center for International Blood and Marrow Transplant Registry. This is the number. You can see blue is allogeneic, green is autologous. And you can see this is 2021. So this is before CAR T, but that the number one indication for transplant in the United States was myeloma for melphalan and plasma cell dyscrasias. Leukemia comes in second, and then lymphoma is third, and then myelodysplasia. So auto, allo, and then some of these others. But myeloma by far is the number one reason why people have undergone transplants in the United States. If we look at what happens over time, this is data from 2022, you could see lymphoma had slowly risen, but it may be a slight dip. This is right when CAR T starting to emerge. As of this point, CAR T for myeloma is not available, but we just basically continue to go up the number of procedures. Again, a dip here in 2021. This CAR T for lymphoma started in 2018. It does fall afterward. What we know here is this is COVID, because many lymphoma patients, when they present, you can't risk not transplanting them. But for myeloma, we've learned over the years that you can just keep their disease suppressed. And so many patients during COVID years, we actually would, just to keep our beds available, we would postpone a myeloma transplant for 6 months or even longer, just so we would have a chance to take care of the patient when we need to. As far as myeloma treatment, for transplant eligible patients, and again, who is transplant eligible? That's often in the eyes of the beholder. If you are a community physician, tends to be, they'll look at somebody, sometimes, I've had patients in their 60s who their doc tells them, oh, you're too old. In my view, transplant eligible is up to age 80 for multiple myeloma. And I've actually done, I believe, 1 or 2 patients over age 80 who had a tremendous performance status. It's because if you get to age 80 and you're healthy, with a new diagnosis myeloma, I still, stand by it. Their chance of getting to age 90 is greater than mine is today. And so helping them along with an auto transplant can be done. But, again, this is a field that is in evolution. Where does it really begin in transplant? Everyone talks about is the IFM 90 study. So we were part of studies in the 80s doing transplant for myeloma. And in the 90s, there was a study in the United States saying, a lot of people were doing transplants, but insurance companies said, well, we don't have proof that that's going to be useful. You need to do a randomized trial. So they actually did organize a randomized trial in the United States. But basically, at the time they were just organizing the first randomized trial, the French reported a randomized trial in 1996. 200 newly diagnosed patients. They were young, under 65, but they did have a Dury salmon stage 2, stage 3 disease. These are some multiple drug therapy. You could be a conventional chemo only, and this is monthly therapy, where you get induction with incristin, melphalan, Cytoxan, and prednisone, and then you go on to an 18 cycles of a alternating BVAP is carmustine with adriamycin, vincristin, prednisone. Or you got an induction therapy, flip-flop, for 4 cycles. Then you went to combination total body radiation and melphalan. This was bone marrow only. This was not peripheral blood stem cells. Growth factors didn't really hit until like the early 90s. So this was still doing the bone marrow. Everybody got interferon alpha for maintenance. Turned out that when you look at the data, it was intent to treat, but a number of patients, on the transplant arm, a quarter of them didn't get to the transplant, and some patients just died, because of disease progression. Some had declining performance status or renal impairment, so they were chosen not to go forth, and another 10 patients had low bone marrow cells. That being said, that's the caveats. Well, sorry, it's a duplicate slide, but these were the results. Despite that, there was event-free survival and overall survival. There was a statistically significant improvement in the event-free survival with transplant. If you look at the median here is only about 16 months. The median here is over 30 months. But interestingly, and I pay attention here, when overall survival was not impacted the first couple years. The overall survival changes over time. Now, what's the interpretation? A lot of people believe this was before we knew about fish results for 1114 versus 414. We just included everybody. So bad risk disease was going to relapse early no matter what. And potentially where you get the benefit is from standard risk there, standard disease. And so we see this separation in survival curve occurring after 2.5 years. And that may be where these were the patients who had standard risk, high risk disease, high risk, they just died early anyways. But then what happened is, with time, the standard risk disease really benefited from transplant, and you see survival benefit. And so you can see here this study was followed up over time. So this is a 7-year follow-up now, and you can see statistical significance across the board for event-free survival for median and for the 7-year event-free survival, and the overall survival also at 5 years. At 7 years was only 25% in standard arm, but up to almost 50% in the bone marrow transplant group. So honestly, this study changed everything, almost in the United States anyways. Relatively in a matter of 12 months, most insurance companies, when they hadn't been covering myeloma transplant, said it's now met the standard of doing a phase 3 randomized trial, and we should cover that. We should provide benefit. Skip that already. So then we start to see other countries doing this, and this was a study from England, the Medical Research Council MRC7 study of high dose versus conventional therapy, published in New England Journal. Patient got 4 to 12 cycles of a standard monthly chemo cycle versus 3 cycles induction, a Cytoxan. Now, peripheral blood mobilized stem cells for the first time, not bone marrow, but mobilized stem cells. And the majority of patients got 200 per meter squared single agent melphalan. A minority got melphalan and total body radiation together, we now know that's a pretty toxic combination for GI toxicity. They also got interferon maintenance. That was a standard of care back in the 90s. But importantly, notably, they allowed crossover. So you could rescue somebody from standard to high dose. And again, 75% of patients got high dose therapy. 25% dropped out from the transplant arm. And in the standard arm, about 16% of patients crossed over for salvage. So those crossovers are going to impact overall survival advantage. That being said, you can see if we look at progression-free survival, absolutely dramatic enhancement by a single consolidation of transplant. I would also point out patients getting standard care got 18 months of chemo. Here, they got 3 months of chemo, a dose of Cytoxan, and a transplant. So 5 months of chemo only, no maintenance other than interferon in both arms, but a really dramatic improvement in progression-free survival as a consequence of high-dose chemotherapy or chemoradiation. If we look at overall survival, also meeting statistical significance, but not as dramatic because in here there was the crossover events and that actually impacted the survival, but still a statistically significant improvement in overall survival. So then the question came is, you know what? We were getting good at this. We know how to deliver melphalan, but maybe more is better. And so what about this became very fashionable is to do what about a tandem transplant? So you would basically take somebody, treat them, induce them, get them to a point you can do a single melphalan transplant, and then they randomized them to a second transplant, typically within as early as 60 days, as late as 120 days. Now, more intensive therapy, but this is another French study, but look at the age, under age 60. The median age of myeloma, reminder, is 68 years. So this is a very selected population, but they still had to have Samanduri stage 3. They all got induction equally at 3 to 4 cycles. You could see CR and very good partial remission was statistically the same between 1 and 2 transplants. If we look at overall survival, though, there was almost a year greater advantage to the second transplant. Progression-free survival was statistically significant, and now it's 7-year overall survival, also statistically significant. Treatment-related death mortality was equivalent. And again, we look at, is there dropout? In the single arm, 85%, 15% dropout, 20% dropout in the tandem. Again, interferon maintenance. And here's what it looks like. Double transplants. This is statistically significant. And that same comment we made earlier, early on, there's really no benefit. But the benefit of the double transplant seems to come after 3 years. And so we again think that this may be a reflection of aggressive disease, and that's where you're going to get your benefit. Well, they went to examine that, and it does turn out that if you have if you do a single transplant, here's the outcome of your single transplant. If you do this is the scheduled tandem transplant, but after the first transplant, if you're a VGPR or a CR, there's no statistically significant benefit. However, if you did on your scheduled double transplant, if at the end of your first transplant, you were just a PR only or stable, that second transplant really made an important difference, suggesting we can now start to subset patients at higher risk for worse outcomes. That's what we're learning over time. So again, that was the tandem versus single transplant. Well, they published in a 7-year, they published ultimately a 7-year follow-up. And again, we see here for tandem transplants, a statistically significant improvement of event-free survival, complete remission rate, and importantly, overall survival. And overall survival from time of diagnosis also improved at 5 years. Well, this became a really important thing to study, and a lot of people were studying this and looking at the benefit of single versus tandem transplant. And you'll notice here, this is, through the 2000s, we had a lot of studies looking at single versus double. And they were looking for where you saw benefit. I'm going to point out that the bottom 5, if you look at hazard ratio, they all favored tandem transplant. This is the sum total favors a tandem transplant. A single trial published in 2008 where they looked at, again, it was smaller numbers, but there they had a hazard ratio saying that the single transplant had a better survival than a tandem transplant. Well, you look at this and you say, well, what does this mean? And I can tell you a lot of people who didn't believe in transplant kept saying they'd point to the Abdel Kelfi study and say, look at that, look at that. Tandem transplant hurts people. Well, what a lot of people missed is that there was a retraction that came later, where the authors of this paper basically said that the data that was presented, where they said that there was worse outcomes, it was inappropriately collected data, and the first author took responsibility, and so they retract. However, again, most people have missed that retraction, and a lot of people still will quote that paper of saying that tandem isn't safe. Well, where can we go next with tandem? Well, if we have a double transplant and can be done successfully, this is really chemo intensification. And if you look at the years when we started this, remember I said the biologics started around year 2000. All of these studies are done in the absence of biologics. And so we're looking to intensify the benefit from standard dose chemotherapy. And so this is a study from Bruno et al. He's from Paloma in Italy, and where they did a chemo induction followed by a transplant. Then they were randomized to a second transplant. Now the data looks pretty good for a second transplant using an autologous, or they did a non-myeloablative allogeneic transplant from a matched sibling using very low intensity, just 2 gray TBI only. 240 patients or so from 5 Italian centers. It was, pretty evenly matched for auto-allo versus auto-auto. Median follow-up was 3 years. Treatment-related mortality was 11% in the allo, 4% in the tandem auto. That's a little higher than we would see today, but trended to significant. The remission rate was much higher in allo. Overall survival is a trend, but the others, the event-free. What does it look like? This excited a lot of people because, now there's our 3-year, where everything seems to be the same. But what we see is in allogeneic transplant, this is progression-free and overall survival. Allo could give you a graft versus myeloma effect. Small numbers, but suggesting maybe we're going to cure people with an allogeneic transplant. And maybe we really ought to study very carefully this concept of autologous followed by allogeneic. United States studies, pathways forward. So I don't know if there's any questions before I go on. I'll just take a breather for a second. Anyone have any questions? No questions? Okay, I will go on. So the United States started getting invested in multiple multi-group studies to try and answer some myeloma questions. This was one of the first questions that came out of ECOG, Eastern Cancer Oncology Group, and it's a simple trial. This is exactly the ATOL study again, the French study, but instead of using chemo followed by auto, it's now going to look at a biologic, Rev index, and looking at transplant versus no transplant. And again, what it showed was early transplant versus, late. This is early transplant, late transplant. This is progression-free survival. that early the transplant seems to be better. But on the other hand, for age, this is the age 65 to 70 group that, that transplant was going to be superior to standard of care. But I mean, it was equivalent to the chemotherapy as far as survival. But when you get to older patients, our earlier application of transplant was going to actually help them live longer. So suggesting you can do your RevDex and then be chemo versus transplant would start to give you a superior outcome. This is where the BMT-CTN came in. So that was the first one looking at a biologic. Well, now we're looking in the modern era. This was the U.S. decided we're going to see if we can duplicate the Bruno paper of auto followed by allo. But now it's actually most of the patients are getting biologic induction. It's also not a small study of 50 versus 50. It's 710 patients. And it was going to be a genetic randomization. You signed up ahead of time saying you would you would take whichever you're doing, either auto or auto allo. And if you then would look for HLA matched siblings, if you had an HLA matched sibling, you could go on to you would go and be randomized to the auto allo. If you didn't have a randomized, didn't have a HLA matched sibling, you go to auto. They did the definition of high risk disease at that time was chromosome 13 deletion, not FISH, but chromosome 13 by metaphases. That's appropriate. And beta 2 microglobulin over 4. So we're now we're starting to, for the first time, look at maybe we can look at subpopulations. And the primary endpoint was 3-year progression-free survival. So everyone got induced. Typically, by this time, they were getting like thalidomide or lenalidomide or bortezomib, but generally 2-drug therapy, not 3-drug therapy. 700 patients randomized. You could see more patients, didn't have a CIV donor, but it was almost a 2-to-1 auto versus, allo auto. But you look at high risk, this was pretty balanced if you looked. Now this was important. Remember the Palumbo data showed what looked like a benefit and a cure. Well, the American trial changes that. What we do is we look at the progression-free survival. This is large numbers, and auto allo versus auto. The p-values, not statistically significant difference. If we look at progression and relapse, this is cumulative incidence of relapse, maybe a little bit less with the auto allo, but at 3 years, no difference. Non-relapse mortality was higher at 12% at 3 years with the allogeneic transplant, typically graft versus host versus the auto. If we looked at the standard versus high risk cohorts, this is combining them all again, suggesting that actually, although again not statistically significant, at 3 years, auto was looking actually better than auto allo at 79 versus 75. On an intent to treat basis, so when you started, and all of a sudden you did note though that the auto had continuous relapse, but if you get beyond 3 years, there did seem to be a plateau, and maybe there was if you could survive the early death associated with the allogeneic transplant, that you may end up getting a graft versus myeloma effect that will translate to a late cure. Again, this is 3-year data. This was the original, the original data, and asking that question about a graft versus myeloma effect. They said, well, you know what about patients who got chronic graft versus host disease? And again, this was only in the auto allo group. If you looked at patients who had no GVHD, they had continuous relapse. But if patients had GVHD, there was only a 20% progression over time. Again, suggesting maybe we were going to see a benefit. Well, we now know there's now long-term benefit. This long-term data have now emerged, a 7-year, our own, long-term follow-up. I think this is at 7 years, or median of 6 years. No difference in overall survival for standard risk. No difference in overall survival for high risk, but for high risk progression free survival, your auto allo was trending to significant improvement of relapse control, where you have about 10% progression free in the auto and close to 30% progression free in the auto allo. And that's sort of shown here for relapse for the standard risk, no big deal. But again, and remember, the definition of high risk here is only an elevated beta 2 or a metaphase chromosome 13 deletion. So not a current definition of high risk. But again, we're seeing maybe a plateau, maybe there's something there. So we've learned something. We've learned that auto transplants can benefit. We've learned that at this point, maybe tandem transplants can benefit. And we've learned that maybe auto allo versus auto is not really, we don't have to recommend that early. And allo, instead of being an upfront recommendation, you could use it for salvage in the future. So the next big question is, what about maintenance therapy? Can we actually help somebody after a transplant by giving them a maintenance? As I said, the European studies used alpha interferon. There is one American study called SWOG 9321, which actually looked in a non-transplant chemotherapy setting. After induction, they used prednisone 50 milligrams every other day versus 10 milligrams every other day, and using the dose escalated steroid as a maintenance, there was a significant benefit to myeloma management. So ask the question, what about doing some maintenance therapy in myeloma? So now we get to 2004, CLGB 100-104. This has been published in New England Journal. This paper has changed the management of myeloma across the world. And it was a very simple trial. You stage somebody, they're under age 70, they got treated for at least 2 cycles, but they could actually have been treated for up to 1 year. They have to have gotten adequate peripheral blood stem cells, a single transplant, in auto transplants done with melphalan. You restage, and as long as there's not rapid progression, you don't want to say, well, I'm going to put someone on a placebo. So if they're stable, a PR or a CR, they're randomized to placebo versus Revlimid, 10 milligrams daily for 3 months. And if stable, hematopoiesis, then you went to 15 milligrams. The objective was to look at time to progression after transplant, and where it was predicted that you would actually increase from 2 years to 3 years. The results were dramatic. It was out of the Revlimid patients, 46 had progression or death. Of the placebo patients, twice that number had either a progression or death event. P was 0.0001 with a predicted 60% reduction of risk disease progression. This study was closed early because when the data come through, there was no way. They stopped the dial and they crossed over everybody who was on the placebo arm. So here is our progression-free survival of Revlimid versus placebo, dramatic improvement of the median. When you look at overall survival, still statistically significant, but the placebo crossed over, so they were changed over to Revlimid, so you could actually re-rescue a group. We now know over 10 years, though, with 10 years survival, it's been shown that this not only has a progression-free survival benefit, but it has an overall survival benefit, where at 8 years, it was approximate, even for the patients who crossed over, it was an 8-year median survival versus about a 10-year median survival for the Revlimid only. And if you stratify by risk, it turned out whether you use elevated beta-2 microglobulin, and these are the different curves. You can let's just look at the solid curve. Here was Revlimid maintenance. Here was the placebo. And what you end up doing is seeing a dramatic increase in the time or the delay in time to progression. This is 1 year, 2 year, here's 3 years. There's subset analysis too, I'll skip that. But what raised a lot of attention though is there was an observation of a secondary malignancy. People identify, they said, oh my goodness, we're seeing some people getting, if they, survived and had disease, they ended up getting second malignancies. It turned out that was not statistically significant. Anyways, I'm about 20 slides away from being done. I think I look at this as part 1. I could also take a break here for the group, and I could continue this on the next session, if that's okay with everybody.
Yes, yes. 20 slide is definitely for the next time.
But again, so the next time I was going to do CAR T and bispecifics, but in a way, I've now taken you up to 2014. In a way, I could do it by time. I've taken you from 1960 to 2014. Next session will be from 2014 to 2024, and that would allow us to cover the next 20 slides of myeloma transplant that moves into CAR T and the role of CAR T, and now the role of bispecifics and how all these therapies are coming together to change the natural history of the patient with multiple myeloma.
Prof, for myeloma, can we say that this is really adult cancer, or it's
No, myeloma is an adult disease. Yes, I was joking when I said the pediatrician would benefit, but I also know it's the #1 reason why people are transplanted. I think one of in the world actually also, just because myeloma is not just a disease that it is increasing in incidence. If you look at it, increasing numbers of patients are developing myeloma. Part of it's better detection; people are sensitized. But also, there just seems to be an enhancement, whether it's environmental exposure, that's linked, radiation exposure, Agent Orange exposure for Vietnam veterans. They're all linked to increasing incidence of myeloma. And now, because we have significant survival benefit, the prevalence of myeloma is quite significant. When we started, if we go back to the days at the original French trial, if you didn't do a transplant, your median survival of myeloma was 2 years total. Now the median survival, and that was for patients under age 60. Now for the patients under age 70, we anticipate a median overall survival based on the data I showed you of 10 years. And the prediction is now, with the improvements that we've made in myeloma care, that a new diagnosis patient who's under age 70 can anticipate a median overall survival of 15 years. That means they're not going to die of myeloma. They're going to die of a heart attack, a stroke, or some other etiology. But they're going to die with a diagnosis of myeloma, but myeloma is no longer causing their death. So,
thank you. Any question from Watanosot for Dr. Richard? Do we have a lot of myeloma here in Thailand?
you do. What you have, though, you do have a lot of myeloma. There is a number of myeloma transplants. I think this is where what's happening, at least from my, talking to your team members on the adult side, as well as from Rock, that and Saranya, who is here, who's going back to Udon, in the private sector, you're limited by people who are willing to pay for their procedure and, come in for the, get the transplant at BDMS. In the public sector, they're limited by the availability of resource. So I say we do, for a population of 4 million that I have here in in Oregon that I draw on, we do almost 100 transplants a year for myeloma. I think, again, the total transplants for every disease in Thailand based on the last time I visited, it was about 240 to 250 total transplants for all diseases. And a lot of it is you have an age limit. I think it's age 65 is probably at age 65. It's going to be hard to get a transplant. But when you have a disease that the median age is 68 when you present, and we have data that tell us that some of the best benefits are in the patients who are over age 70. I mean, that's one thing that it's a public health challenge, but that would be a great project to undertake, is to look at the transplants done across Thailand for myeloma, look at their outcomes. We can compare it to what we do in the United States, and then say, is there room for expansion? Because they're absolutely, you've got the numbers. As I said, we did 100 myeloma transplants for 4 million people. You've got a population of 70 million or more, 72 million, 74 million. The myeloma patients are there waiting to be treated.
I think right now, just your center alone doing half of the whole country of Thailand transplant per year, based upon 100 versus 250, you said. That is
Yeah.
a great number.
No, that's partly, I think, why what my plea is to you all the time is, when we think about creating strategic plans and growth, and maybe that will be a big focus of my next visit, is how do we actually, we talked about, you guys have growth plans. Every one of your hospitals have expansion programs, planning for more patients. Your teams are better. You have the facilities, you're hiring the people. But we want to treat the people who need to be treated. We just have to figure out how.
Any question from the round table for Dr. Richard before we finish?
Okay, well then I will let everyone. I will bring this to close. I promise that there will be part 2. Will be myeloma 2014 to 2024. I have a planned presentation also coming up, where on one of those requests was, I have one of my team members actually took a year off to get to do geriatric training, specifically focused on delirium. And she's agreed to give us a special presentation on delirium in the transplant patient population. As a matter of fact, they've organized a coalition in the United States American Society of Transplant and Cell Therapy, and they've now created a new entity of transplant associated, not neurologic toxicity, but psychologic toxicity and delirium. She's the lead author on that paper, and I've invited her to be part of our future sessions. I think it'll be very instructive for everybody. Delirium is out there, whether it's drug related or sometimes other factors. It's commonly, experienced. And I know we'll have presentations coming for your teams too.
Yes, Prof. Thank you very, very much once again for the back to the future, what should I say, back to the history until 2014. And we look forward to more recent period.
Part
treatment.
2.
Yes, part 2 later.
Yeah.
Thank you
And
very much.
as I said, from Surapol's request to me is, he says so many people don't know the history. And so he really likes it when we present in these grounds where we get the history of how did we get to where we are today. And so that's what I tried to help deliver. And if you see him personally, give him my my sincere considerations for him.
Yes, we'll do. So sad news for him this morning, such a big blow.
I'm so sorry.
Yeah. Thank you very much, Prof. Bye-bye.
Okay, everybody, have a great weekend and a good month.
Yeah, you also.
Okay, bye-bye.
Bye-bye. Yeah, bye.
And thanks for listening, everybody, including my pediatric colleagues.
You made me like go back to the medical student.
Yeah, well, good. Well,
But
you know,
it's
when you
good.
next
It's
time
good.
next time you come, you can round on the adult service.
Yeah, yeah. Okay. Thank you so much. Bye bye, for
All right. Bye
yeah.
bye.